This is part 3 of a series of lectures on antimicrobial resistance and antimicrobial stewardship in veterinary medicine. In this part, we'll be talking about the pharmacodynamic factors that influence dosage and the therapeutic response to antimicrobial drugs in veterinary medicine. Some antimicrobials have a time-dependent bactericidal effect. For the beta-lactams and the lincosamides, the time that plasma levels exceed the MIC, or the minimum inhibitory concentration, is the most important pharmacokinetic property affecting their efficacy. For these drugs, the plasma concentration needs to exceed the MIC of the pathogen for most of the dosing interval. Therefore, dosing needs to be done frequently or use made of prolonged release formulations. So in this graph, ensuring plasma levels remain above MIC, the dashed blue line, requires a dosing interval of about 6 hours. It's particularly important to ensure that the trough concentrations remain above the MIC for optimal bactericidal effect. You can also see here that if we know the peak plasma concentration we can achieve with a particular dose of our antimicrobial drug, its plasma half-life, and the minimum inhibitory concentration of the drug for the bacterium we need to treat, we can ensure that our therapy is optimal. In this graph, a long-acting preparation has been administered. Such a repository formulation of the antibiotic can give us more prolonged therapeutic levels, but the peak level is much lower than the previous example. The main potential issue with these preparations is that the release of the drug needs to be sufficiently rapid to ensure plasma concentrations reach the MIC. Other antibiotics exhibit concentration-dependent bactericidal effects. For the aminoglycosides and fluoroquinolones, the peak plasma concentration, or the Cmax, in relationship to the MIC, is the most important factor in determining optimal dosing. It is not necessary or desirable to maintain serum levels in excess of MIC because of the post-antibiotic effect of the drug, and this is a factor we'll explain a little later. For optimal bactericidal effects, we need to aim to achieve a plasma Cmax about 10 times the MIC of the organism being treated. Maximising the bactericidal killing rate reduces the risk of regrowth of a resistant subpopulation. Optimal dosing can also be determined in terms of the ratio of the area under plasma concentration curves over 24 hours, or the AUC 0 to 24, to the MIC. A ratio of 125 to 1 is optimal for fluoroquinolones. Here you can see that the trough concentrations have fallen below the MIC. However, when the drug exerts a post-antibiotic effect, dosing can be delayed even though plasma concentrations have fallen below the MIC. Older dosage regimens for aminoglycosides did not take account of this effect, and dosage intervals of 8 hours were recommended in an attempt to keep plasma levels above MIC throughout the period of therapy. These more frequent dosage regimens were less effective and had a higher risk of toxicity than the less frequent regimens that are now recommended. Some antibiotics have a first exposure effect on bacteria. In these cases, bacteria that survive initial exposure to an antimicrobial can be unsusceptible to a repeat exposure for a period of time afterwards. This is thought to be because the drug has had an effect on the systems needed for import of the drug into the bacteria, or on the enzymes that are needed for the drug's activation inside the bacterial cell. Some drugs can also have a post-antibiotic effect, or a PAE. In this situation, there is continued suppression of bacterial growth after removal of the antimicrobial drug. This effect is dependent on the class of antimicrobial agent, the type of microorganism being treated, and the concentration of the drug and the length of time of exposure to it. Inhibitors of protein synthesis, such as aminoglycosides, and inhibitors of DNA replication, such as fluoroquinolones, have prolonged post-antibiotic effects against gram-negative bacteria, but the beta-lactam antibiotics do not. However, a post-antibiotic effect can be seen with beta-lactams against some of the gram-positive bacteria. This effect is thought to be a result of an extended effect on protein synthesis and or replication, and of the retention of the drug in the bacterial cell. It is this post-antibiotic effect, and the first exposure effect we talked about previously, that is the key to the less frequent dosing regimens that are used for antibiotics with concentration-dependent effects. Antibiotic therapy is always a calculated risk that the drug's more selective toxicity for the microorganism occurs before there are toxic effects on the patient. Antibiotics vary in their toxicity. The beta-lactams are relatively non-toxic, while the aminoglycosides are highly toxic. The organs and systems affected include the kidneys, the nervous system, the liver, the heart, and the hematopoietic system. Patients with known liver or kidney insufficiency should be closely monitored and dosages adjusted to avoid or minimise toxicity. Patients may develop allergic reactions to antimicrobials such as the penicillins. This may be manifested as acute anaphylaxis, although more commonly the effect is milder with signs such as urticaria and fever. Adverse interactions can be seen with other drugs, including the anaesthetics, particularly with the aminoglycosides, chloramphenicol and the tetracyclines, and with oral anticoagulants, with the sulfonamides. Antimicrobial drugs in general can have effects on the normal flora of the animal. In some cases, this can result in superinfection, where the removal of the inhibitory effect of the normal flora on a body surface allows one particular bacterial species to dominate. Superinfection is particularly associated with the broad-spectrum antibiotics, but it can also occur with lincosamides, which are excreted in an active form into the gut, and is particularly a problem in animals with expanded large intestines, such as horses and rabbits. Selection for antimicrobial resistance, a focus of later lectures in this series, is a major problem that follows antimicrobial usage. Tissue necrosis can occur at the site of injection, particularly with tetracyclines and macrolides. Non-specific inhibition of protein synthesis is a particular problem with chloramphenicol and can result in poorer wound healing, lowered prothrombin levels, and also reduced immune responses. Drug residues are a major concern in animal products used for human food, so in all treated food animals, withholding periods must be observed. A bactericidal agent should be used in serious life-threatening infections, and also when host defences are impaired or not fully functional in immunosuppressed or immunodeficient animals, and when treating meningitis or endocarditis. Adjunctive therapy is often critical for therapeutic success. You should always drain abscesses, remove foreign bodies, debride necrotic tissue, and irrigate exposed infected tissues. Combined antimicrobial therapy should only be used with considerable caution and with a clear understanding of the potential interactions between the different drugs. Depending on the antimicrobial agents, the effect may be additive, with the total effect the sum of the two drugs, synergistic, with the total effect greater than the effect of the two drugs, or antagonistic, where the total effect is poorer than either one of the drugs acting alone. In general, when you use two bacteriostatic drugs, the effect is usually additive. When you use a bacteriostatic drug and a bactericidal drug, the effects may be antagonistic. And when you use two bactericidal drugs at the same time, the effect may be synergistic. Combined therapy with two or more non-cross-resistant drugs is sometimes justified to try to prevent the selection of drug-resistant subpopulations during treatment of chronic infections, and an example of this is treatment of Rhodococcus equi infections in horses. Finally, a word on antimicrobial prophylaxis. It is not generally recommended unless it can be justified, for example, prior to intestinal surgery. It should never be used as a substitute for poor aseptic technique. Routine clean surgeries, such as ovariohysterectomies, do not require antimicrobial prophylaxis. When prophylaxis is used, the best evidence suggests it should be administered prior to surgery, not afterwards. This ensures the drug levels are at the site of incision when surgery commences. Off-label use of antibiotics, or of any drug, is a right of veterinarians, but this use should always be scientifically justifiable and probably should be supported by a microbiological diagnosis. Considerable caution is needed in food animals, as data on withdrawal times is not available. Two final considerations that should be borne in mind. Antimicrobials should only be used in situations where they may be reasonably expected to make a difference in the clinical outcome of the case, and should never be dispensed just because the client demands them. And finally, it is important to be aware that dosage recommendations on some of the labels on antimicrobials are incorrect, as they have not been updated for 20 years or more. You should always check with the current textbook to see what the optimal dosage rates and intervals are for the drug you are administering.